Bismillahirrahmanirrahim. Can you hear my voice?
Yes.
Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And very good evening. I meet to our supervisor, Dr. Shahid, and also our colleagues. So for today, I will be the first presenter, which will be present about the topic of immune thrombocytopenia, or also known as ITP. So my name is Nurul Akila binti Darmawan with matric number Y912074. So for this topic, I will present about the introduction, followed by the pathogenesis, and then the clinical manifestation. After that, the depression diagnosis is related with the presentations of the purpura or easy breathing, and then diagnosis that include the history, physical examination, and also investigation, and lastly, management. So first one is introduction. So from the name itself is immune thrombocytopenia. So immune in this case is a condition which is caused by the activations of the immune system by the productions of antibody that against our own platelet. And due to that, it leads to low platelet count, which is thrombocytopenia. So ITP is considered as an autoimmune disorder, which is characterized by autoantibody mediated immunologic disruptions of normal platelet. This mainly occur in the skin and in response to an unknown stimulus. And in acute childhood ITP, it's usually benign self-limiting disorder and presenting with isolated thrombocytopenia, which is the platelet count will be less than 100 times 10 to the power of 9 per liter, and also in the absence of underlying causes. 5% of patients may have a recurrence of acute ITP, while 10% of patients may also develop persistent chronic ITP. And previously, ITP was also known as idiopathic or immune thrombocytopenic purpura. However, this term is outdated, and the term purpura itself has not been used because most of the patients are asymptomatic. So in terms of epidemiology, in children, the peak age is around 2 to 4 years old, and the prevalence occur in about 4 to 5.3 in 100,000 children. For ITP in children, it equally affects girls and boys. For the classification, we can classify ITP into the acute or chronic ITP. For acute, usually the duration takes about 1 to 2 weeks. However, for chronic, there is persistent thrombocytopenia, which occur about more than 6 months duration. Acute ITP commonly occur in children, while the chronic commonly in adults or teenagers, which is more in female. While for acute ITP, it can equally affect both female and male. Acute presentation is rapid onset compared to chronic, which is insidious onset. And for the acute ITP, it usually precedes by viral infection, which majority of the history majority will give a history of viral infection preceding about 2 to 4 weeks before. And for the chronic, it related with idiopathic or secondary causes of thrombocytopenia, which this will can be associated with autoimmune disorder like SLE or APS, antiphospholipid syndrome, malignancy like lymphoma or leukemia, infection like HIV or hepatitis C virus, drug like sulfonamide or heparin or vaccine. Next. Mm. So, according to its protocol, it has classified ITP based on the phase of the disease. So, for newly diagnosed ITP, it occurs within 3 months from diagnosis. While for persistent ITP, it occurs between 3 to 12 months from diagnosis. It includes the patient the not reach spontaneous remissions or not maintain complete response of therapy. For chronic ITP, it can be last for more than 12 months. And for severe ITP, there is presence of bleeding symptoms at presentation that's sufficient to mandate the treatment, or occurrence of new bleeding symptoms that need additional therapeutic intervention with a different platelet enhancing agent or an increased dose. So the treatment recommendation can be varied according to the durations of ITP. Next is pathogenesis. So as mentioned before, this ITP, it is autoimmune disease and mainly is idiopathic. So what happened? The exact causes of ITP is remain unknown, but usually patients in ITP will produce anti-platelet IgG autoantibody, which this autoantibody will be directed to platelet surface protein, mainly GP2B3A complex. So this GP2B3A complex located at the surface protein of the platelet and really important for the platelet aggregation. So when the platelet surround with the autoantibody on their surface, it will be later on trapped in the spleen, and later it will be removed by minute macrophage. This will lead to reduction and also destructions of the circulating platelet in the bloodstream. And sometimes, in some cases, antibody also maybe react with the developing megakaryocyte, which is a platelet precursor. So this also can lead to decreased productions of the platelet, leading to thrombocytopenia. So what happens when there is thrombocytopenia? This will reduce the lifespan of the platelet in the bloodstream, and then our body, which is mainly in bone marrow, will attempt to increase the platelet production. This will lead to increased release of the immature platelet from the bone marrow. As we can see from the peripheral blood film, it will result in increased immature or larger platelet, and also lead to increase of normal megakaryocyte that can be found in bone marrow biopsy. And at the same time, when there's thrombocytopenia, which is when there's no platelet, a platelet will not be enough to uh, to form a platelet clot, which is important for hemostasis for the bleeding. So this can lead to clinical manifestation that can occur in ITP, which is like bleeding under the skin that lead to red or purple discoloration, such as PTK, purpura, or ecchymosis that vary in terms of diameter. It also can lead to mucosal bleeding like nose or gum bleed, and for serious cases, it can also lead to intracranial bleed. So the next one is clinical manifestation. So the onset of ITP is usually abrupt and acute, mainly in especially in children. The majority will give a history of viral infection that precedes about 2 to 4 weeks before. And most commonly, it is asymptomatic, but symptoms and signs represent highly variable, which it can range from the common asymptomatic patient with mild bruising or mucosal bleeding to frank hemorrhage that can come from any side, and the most serious one, which is intracranial bleeding. So basically, for the cutaneous bleeding, patient may there's presentations of PTK, purpura, or ecchymosis, which is varies in terms of the diameter. If PTK it is less than 2 mm, purpura, the reddish skin discoloration, obverse is about 2 to 10 mm, and ecchymosis is more than 10 mm. For mucosal bleeding, there's unexplained gum bleeding or epistaxis, and there's also pre-hemorrhage from any side. This is less common, uh, which the presence of uh, unusual menorrhagia, especially in the teenage girl, hematuria, or severe gastrointestinal like melena. And the severe one is a life-threatening bleed, which is very rare. It involves the intracranial hemorrhage, and it's very rare, because it occur about 0.1 to 0.5%. So next is differential diagnosis. For this is differential diagnosis when children presented with purpura of easy bruising. So purpura and easy bruising, it can occur due to thrombocytopenia or reducing platelet count, and sometimes even a normal platelet count also can cause purpura or easy bruising. For thrombocytopenia, it may be due to increased platelet destructions or consumption, which it can be due to immune or non-immune. So for immune, the most common is ITP. Other than that is systemic lupus erythematosus or SLE. For non-immune that can cause over-destructions of the platelet overconsumption, it involves hemolytic uremic syndrome, thrombocytopenic purpura, and also disseminated intravascular coagulation. Besides over-destructions of platelet, impaired platelet production also can lead to thrombocytopenia. So this can be congenital or acquired. So for congenital, it may due to pancreatic anemia or Wiskett-Aldrich syndrome. For acquired, it can be due to aplastic anemia or drug-induced, and also leukemia itself. And sometimes we also may consider even with the normal platelet, which is such as the severe infection or meningococcal infection or heinous swelling purpura. So now, in terms of the diagnostics. So ITP is actually its diagnosis of exclusion. Therefore, we need to exclude um, other secondary causes that can lead to thrombocytopenia. So according to CPG, the diagnosis can be made clinically based principally on the history, physical examination, where there's no stigmata of malignant disease like leukemia or congenital thrombocytopenia, and uh, from the full blood count, there's isolated thrombocytopenia, and the examinations of peripheral blood smear also will exclude the abdominal cell. So for history, as the ITP will be presented with a purpura of easy breathing. So we need to know about the bleeding symptoms to determine the extent and durations of the bleeding, and also the severity of the bleeding itself. So we can ask about the spontaneous, we can look at the spontaneous mucocutaneous bleeding. Is the patient presented with frequent or prolonged bleeding? And for if it is teenage girls can ask about the excesses of prolonged menstrual bleeding. And sometimes, because of the complication of ITP, it can lead to ICH, intracranial hemorrhage. So we can also ask the patient to elicit the sign of symptoms of the intracranial hemorrhage, which is include the headache, blurred vision, or loss of consciousness, or any recent head trauma. For systemic system, we can ask about fever, mainly to exclude a current viral infection like HIV or HPV that can cause thrombocytopenia. Weight loss to exclude a malignancy like acute leukemia. Usually in ITP, from the current presentation, it should not be present with fever, but it usually has had a history of viral infection 2 to 4 weeks before, which this can uh, lead to one of the presentation of the ITP. And then autoimmune disorder symptoms like atresia, skin rash, and alopecia to exclude the autoimmune secondary causes of thrombocytopenia like SLE or APS. And then risk factor for HIV, HPV, or HPV like perinatal transmission of the virus. Drug history also important because there is a drug-induced thrombocytopenia, which these drugs such as aspirin, sulfonamide, heparin, and quinidine also can cause thrombocytopenia. And if the patient had recent history of hospitalization, we also can ask about the medication given from the previous hospitalization uh, to know that it is related with the current presentation. And then family history of bleeding disorder to exclude the congenital blood disorder. Next is a physical examination. So from the physical examination, we look at the bleeding sign, where this mucocutaneous bleeding like TK, purpura, and ecchymosis. Usually these bruise, it is not palpable and not manageable, which is when we put a pressure on the bruise, it will not disappear. And for lymphadenopathy, usually in ITP, there's no lymphadenopathy and no hepatosplenomegaly. If there's presentations of lymphadenopathy or hepatosplenomegaly, this can exclude the diagnosis of ITP itself. And then signs of autoimmune disorder like skin rash, goiter, and vasculitis to exclude the other autoimmune disorder like SLE. Next is investigation. So for investigation, we can see from the full blood count, there's isolated thrombocytopenia where there's reduced in the platelet count only, about less than 100 times 10 to power of 9 per liter. And other blood cell like hemoglobin and white blood cell count will be normal. And after that is peripheral blood film. Peripheral blood film will show the normal morphology of the blood cell. Beside from reduced or larger platelet, and there's no other abnormal cells. For coagulation profile, it can cause a prolonged bleeding time because reductions in the platelet count cause leading to destruction of hemostasis, causing the bleeding to occur more prolonged. And then for bone marrow examination, it can be indicate if the patient not respond to the therapy or before starting steroid, especially patient that we suspect to have malignancy like leukemia. And the result show there's increased megakaryocyte for patient who have ITP. And it also be done to exclude the infiltrative disorder like leukemia. Autoimmune profile also can be done, such as anti-nuclear antibody, anti-double-stranded DNA, and antiplatelet. Also to exclude or to rule out the other autoimmune disease. And HIV screening is one of the risk factors. So, especially it can be done especially for the patient that has risk to get HIV. Example like parent with HIV infection. Yeah. Next, uh, next is about management. So for management, since most of the ITP, uh, children with ITP can recover without treatment. So not all with acute ITP need hospitalization. So actually about 75% or 80% of the children can recover completely from the ITP within about 6 months. So one of the management that can be done is first advise the patient and also family by precaution with physical activity, especially that potentially expose the children to trauma. Also avoid the contact sport like wrestling, rugby, or football. Other than that, seek immediate medical attention if there is significant bleeding, and also avoid taking aspirin or NSAID because we need to avoid the medication because it can put the children at risk for bleeding. Example like aspirin, it can cause gastric bleeding. Other management is observation and monitoring of the platelet count without specific treatment. So we can observe, monitor the platelet count more than 20 times 10 to the power of 9 per liter without bleeding. Uh, um, platelet counts more than 30 times 10 to the power of 9 per liter with cutaneous purpura only. And we also need to do repeat FTC within first 7 to 10 days to ensure that there's no bone marrow disorder. Apart from that, is hospitalization, which this will be indicate if the patient had presented with severe life-threatening bleeding, like intracranial hemorrhage, and regardless of the platelet count itself, or if the platelet count is less than 20 times 10 to the power of 9 per liter with bleeding, or if the platelet count is less than 20 times 10 power of 9 per liter without bleeding, but inaccessible to healthcare. And lastly, it's lack of confidence in home care. Okay, so an treatment that can be given uh, for patient with ITP is usually indicate if there is life-threatening bleeding episode of platelet count less than 20 with mucosal bleeding. So the treatment of choice include the oral prednisolone and IV immunoglobulin IVIG. Usually for the oral prednisolone, we will give 2 milligram per kg per day for 14 days, and then we tapered off over 5 days. Or we also can give 4 milligram per kg per day for 3 to 4 days. Another treatment option is IV immunoglobulin. where we give 0.8 gram per kg per dose for single dose. And usually the side effects of this IVIG are common, which it can cause fever, flushing, headache, nausea, septic meningitis, or also can lead to possible transmission of blood-borne infection. Okay. In emergency treatment, which is for those with severe bleeding, like severe episodes of GIB, that can lead to drop of hemoglobin, or also involve the intracranial hemorrhage, you can give IV metoprolol, about 30 milligram per kg per day for 3 days, or combinations of IV, IG, and metoprolol in life-threatening condition, or platelet transfusion, which this platelet transfusion it only help to increase the number of platelet in a short time, and help the body to stop the bleeding. And if the other modalities fail, we might consider an emergency splenectomy. So this is the summaries of the treatment. So previously what I explained is more to acute presentation. So for chronic ITP in children, the management is mainly to allow the chronic ITP children to remit spontaneously as far as possible, because it can limit. However, if there's bleeding occur, if it is acute one, we can manage by using by giving the steroid of IVIG. If the bleeding is recurrent or also affect the patient lifestyle, we can suggest a second life therapy. But for second life therapy, it should be consult with the pediatric hemologist first, which this second line therapy include the steroid like dexamethasone or oral metoprolol. And sometimes NTT also can be suggested, NTT immunoglobulin suggested in the rhesus positive patient. I think that's all for me. Thank you.
I think can proceed with the next presentation. Soalan boleh pun untuk at the end nanti lah.
Assalamualaikum warahmatullahi wabarakatuh. My name is Siti Nurshah Zwina, and I'll be presenting on thalassemia. This is the outline of my presentation today. I will start by introducing the thalassemia, its pathophysiology and clinical presentations, complications, and how to initially investigate and further investigation of thalassemia, differential diagnosis, and lastly, how to manage thalassemia patients. Okay, first of all, thalassemia is a genetic disorder. Patient inherit as an autosomal recessive. The pathology is due to reduction in the synthesis or total absence of synthesis of the involved globin chains, and the end result is hemolysis, ineffective erythropoiesis, and hypochromic macrocytic anemia. There are two main types of thalassemia in Malaysia, alpha and beta thalassemia. So as we know, in hemoglobin, we have the heme group and the globin chains. The heme group contain iron, and the globin chains, we have 4 globin chains in one hemoglobin. So there are 4 types of globin chains: alpha, beta, gamma, and delta. So each of different types of hemoglobin, when combined, will produce different types of hemoglobin. For example, in the hemoglobin F, we have 2 alpha and 2 gamma. In hemoglobin A, which is the most hemoglobin in adults, most type of hemoglobin in adults, it is made up of 2 alpha and 2 beta. And lastly, the hemoglobin A2, which accounts for the small fractions of adult hemoglobin, is made up of 2 alpha and 2 delta. So, for example, in beta thalassemia major, where there is absolute absence of beta globin chain synthesis, so this means that instead of we have 2 alpha and 2 beta in globin chains, now we have all alpha, for example. So this excess alpha in hemoglobin A will this excess alpha is insoluble and not stable in nature. So this excess alpha will precipitate in the RBC, and when this abnormal hemoglobin travels to the spleen, it will hemolyze, where it will be engulfed by the splenic macrophage. The bone marrow will try to compensate for the loss of hemoglobin by producing more red cells. But as we know that the hemoglobin is made up of heme and globin, and to produce hemoglobin A, we need to have 2 alpha and 2 beta. But in beta thalassemia major, we have absolute total absence of beta globin chain synthesis. So what happened? So the hemoglobin that is being produced is abnormal and very immature, and also there's lot of excess alpha chains. So this results in ineffective erythropoiesis. So the combination of hemolysis in the spleen or in the blood vessels combined with ineffective erythropoiesis due to bone marrow tries to compensate for the lost RBC will result in the anemia. And the type of anemia is hypochromic microcytic. So the epidemiology, so I take the epidemiology from a study where the data where the data is collected from 2017 until November 2018 from government hospital and university hospital all around in Malaysia. So they recorded 8,861 patients with thalassemia. And for the gender distributions, men to women ratio is almost equal. For the geographic distributions, most patients with thalassemia came from the state of Sabah, followed by Selangor, Kedah, and Johor. For the age group, most patients with thalassemia came from age group of 5 to 24.9 years old, and the number of patients is decreased in the older age groups. And also in our hospital settings, usually patients with beta thalassemia will present to the ward with anemic symptoms at age of 6 months old due to the transmission between the hemoglobin F to hemoglobin A. And for the ethnicity distributions, thalassemia patients, a majority came from Malay, followed by Chinese, Kazakh, and lastly, small portions from Indian. So in all, thalassemia is very prevalent in Malaysia, where mostly mainly among the Malay and Chinese communities. The next is the pathophysiology. So the causes of the mutation is due to point mutation or deletion. In the alpha thalassemia, it is due to deletion at least one of the 4 alleles at chromosome 16. And for the beta thalassemia, it is due to point mutation, often in the splicing sites at the short arm of chromosome 11. For example, in beta thalassemia, there is a point mutations where this single nucleotide in the DNA is replaced by another nucleotide, often in the splice sites located at the chromosome 11. So this mRNA cannot read these mutated genes. So as a result, it leads to the mutations, either results in reduced beta globin chain synthesis or total absence of beta globin chain synthesis. So dig further into different types of thalassemia, in beta thalassemia, it is, you know that it is an autosomal recessive. So it means that we need two copies of gene mutations from both parents to develop the disease. For example, in beta thalassemia major, we need two copies of mutated genes from both parents, from the mother and the father, for the patients to develop the disease. In this case, when the patient inherit the gene that encode for total absence of beta globin chain synthesis, the patient will present clinically as beta thalassemia major. And in this and another case, if patients inherit the gene mutations from both parents that encode for reduced synthesis of beta globin chains, patient can present clinically as beta thalassemia intermedia. In comparison to this case, when the patient inherit only one gene from both parents, they will present clinically as beta thalassemia minor or as carriers. As for the alpha thalassemia, beta thalassemia is due to point mutation, but in alpha thalassemia, it is caused by the gene deletions in the alpha genes. So in these chromosomes, we have 2 alpha in each copies. So altogether, we have 4 alpha genes at chromosomes 16. So when there is one deletion, the patient only manifests as silent carrier, and patient have normal complete blood counts like normal adult, like normal people. But if patients have 2 alpha genes deletions, patient may have microcytic anemia, and patient known as alpha thalassemia traits. But if there is 3 gene deletions here, patients will have microcytic anemia and hemolysis, but patient does not need transfusion. Patient is not transfusion dependent, and patient is known as hemoglobin H. However, if there are 4 gene deletions, all the alpha genes are mutated, this is the most pathological, where patient will present with hydrophilitis, or known as hemoglobin buds, and in this patient they will die in the utero or immediately after the birth. So in alpha thalassemia, the severity of the symptoms is depends on how many gene deletion occurs. Okay, the next is the symptoms of thalassemia. When clocking patients with thalassemia, in general history, we ask for the pale symptoms due to hemolysis and ineffective erythropoiesis. And the next is the yellowish discoloration, jaundice, also due to hemolysis, growth retardation, and delayed puberty due to endocrine problems. Endemic symptoms such as lethargy, fast heartbeat or palpitation, shortness of breath, dizziness. And for the pediatric history, as for the birth history, either patient is IUGR or neonatal anemia or have T6PD deficiency and any developmental concern. And the next is for the past medical history or past surgical history. As if patients already have underwent splenectomy, if yes, why and when. Next is the drugs and allergy history. Ask for any allergy to the drugs or food, any supplement taken at the moment, medications, and their compliance. The next is the family history. Ask for the genetic status. Either they have done the genetic screening. Also ask for other family history of thalassemia in the first and second degree relatives. And the next is social and literary history. Ask for the school performance, the academic, and their attendance to schools. Next is psychosocial, their behavior, or they have low self-esteem, relationship status, and also depressions. And next is the dietary intake. Either patient is on restricted diet, like low iron-rich food intake. Next is signs of thalassemia. From general inspection, we can see signs of anemia, conjunctival pallor, and next is the jaundice at the sclera. We can also, patient might also have thalassemic phases due to bone marrow expansion. So patient will manifest as the presence of frontal bossing, maxillary overgrowth, foramen malar eminence, and dental malocclusions. But next is the cardiovascular examinations. Palpate for the apex beat, either displaced or there is presence of murmur because of the iron deposition in the cardiac muscles. So patient can present with signs of heart failure, such as cardiomegaly. But this often can be found in all the patients. Next is the abdomen examinations. Look at the surgical scars from the splenectomy. Splenomegaly due to excess alpha chains that is precipitate in the RBC. So the spleen will engulf, spleen will trap this RBC and cause extravascular hemolysis. Spleen may enlarge. The next is hepatomegaly, also due to extramedullary hematopoiesis. The next is look at other complications of thalassemia, for example, hypothyroid signs, dry scaly hair, and hyporeflexia. Okay, next is the complication of thalassemia. First is the cardiac involvement, as said before, due to iron deposition in the cardiac muscles, and also the chronic anemia. So the iron deposit in the cardiac muscle cause the muscle to less contractility. So patient can present with symptoms and signs of heart failure. The next is the bony deformities, such as osteoporosis due to nerve expansion and endocrine deficiency. And next is hepatosplenomegaly. So this often we encounter this patient in daycare and ward, right? But others might not develop yet in young patients. So in hepatosplenomegaly, hepatomegaly due to liver cirrhosis because of the iron overload, splenomegaly due to extravascular hemolysis, and also can be result from extramedullary hematopoiesis. The next is the endocrine abnormalities. Patient may present with lots of many metabolic disorders due to iron overload at different sites. The first is patient may have growth hormone problem. So patient present with poor weight gain, growth retardation, and short stature, and also patient may have risk of diabetes mellitus and hypothyroidism. The next is the antibody formations. So the autoantibodies to the transfused red cells in the patient make finding compatible blood very difficult. So lastly, the infection came from the blood transfusions. So patient have risk, although now it is uncommon because of the infectious screenings, but patients may have little risk to develop blood-borne infections. So this is the common complication, and others you can read here. So how to investigate for the thalassemia. The first is the baseline complete blood count. So patient is having the hypertrophic microcytic anemia. So we can expect low hemoglobin, low MCV, and low MCH, and also increase in reticulocyte counts. The next is the hemolysis evaluations, negative COM test because it is non-immune mediated anemia. Next, decrease haptoglobin, increase LDH and increase reticulocyte counts. And for the liver function test, increase indirect bilirubin. All of this is because of hemolysis. The next is peripheral blood flow. We can expect these findings and anisopoic keratinocytosis, different size of shapes, different size and shapes, target cells, and teardrop cell. So for the confirmatory investigation, we have three. First is hemoglobin electrophoresis, when we screen for the abnormal hemoglobin. So we can expect increase in hemoglobin F and hemoglobin A2 and markedly low hemoglobin A. And this also can be done for H inclusion test for alpha thalassemia. The next is high performance liquid chromatography to quantify hemoglobin A2 and hemoglobin F. So there is increase hemoglobin A2 in heterozygosity or severe form of beta thalassemia, and also a moderate increase hemoglobin A2 in mild case. The next is the DNA analysis to identify globin chain synthesis and structure analysis, and also it is required when we cannot confirm the thalassemia by hematological test, and also it is done for the genetic counseling and prenatal diagnosis. So the differential diagnosis of thalassemia includes sickle cell anemia, where it is the genetic defect causing the sickle hemoglobin due to point mutation from glutamic acid replaced to valine. The next is iron deficiency anemia. It is loss of iron. The next is hemolytic anemia, the autoimmune towards RBC, and lastly, anemia of chronic disease. So the management of thalassemia, it depends on types of thalassemia. Generally, to manage thalassemia patients, we want to avoid the complication, the iron overload complications. If we want to avoid extramedullary hematopoiesis, so we introduce a hypertransfuse regime, such as the blood transfusions, and also from the blood transfusions, we need to monitor for the iron overload, because patient can die from the complication of iron overload when the iron will deposit in the cardiac muscles. So patient can die from the heart failure. Patient might not die from anemia, but patient can die from the complication of iron overload. So firstly is the blood transfusions. For the beta thalassemia major, we will transfuse once diagnosed, confirmed, or if the hemoglobin is less than 7 gram per deciliter, and with the target. Our target is we keep the mean hemoglobin level between 12 to 12.5 gram per deciliter, and for beta thalassemia major, it is 4 weekly interval. So that's why they also call as transfuse dependent patients. So the PEG cells is PEG cells depends on their pre-transfusion hemoglobin and also their weight. Next is the alpha thalassemia. We start transfuse only if patient is asymptomatic or persistently low hemoglobin, less than 7 gram per deciliter. And for the thalassemia intermediate, generally patients do not require monthly transfusion as their hemoglobin levels runs at about 7 to 9. But however, if their hemoglobin less than 8, and also there's evidence of impaired growth due to anemia, so we will start transfuse, but not monthly like thalassemia major. The next is the iron chelating therapy to prevent the iron overload, because like I said, patient can die from the complication of iron overload. So to introduce the chelating agents, especially in the transfusion dependent or beta thalassemia major patients. So the examples of chelating agents include desferrioxamine, diferipron, and diferesirox. The next is the diet and supplement. We will introduce patient with orofolate, vitamin C. Vitamin C, avoid iron-rich diet in patients, and also encourage patient to drink tea as it can minimize iron absorption. So the next management is splenectomy. It is indicated if patients have hypersplenism, because it can cause recurrent infections or bleeding, or patients have clinically significant splenomegaly, so patients might not comfortable because of the abdominal distension and abdominal pain. And also splenectomy is indicated when there is uncontrollable iron overload disease and anemia. And lastly, the bone marrow transplant. Well, however, we need HLA compatible from the family, and the patient is classified into Pesaro risk group based on the presence of 3 risk factors like hepatomegaly more than 2 cm, individual iron circulation and presence of fibrosis. Okay, so this is the last slide. How to club patients with underlying thalassemia, because we often encounter patients who are electively admitted for blood transfusions in the ward, right, or in the daycare. So first is for the HOPI, we ask for the age of diagnosis and how the patient was diagnosed. Either patient came to the casualty for the endemic symptoms, or it is incidental finding during the regular follow-up, and how the subsequent management, and any complications to the transmission or from the thalassemia itself. Okay, so that's all. Thank you.
Okay, can proceed next topic.
Assalamualaikum. Can you
Sekejap.
okay? Okay, Assalamualaikum warahmatullahi wabarakatuh. My name is Muhammad Fakhruddin bin Muhammad Lutfi, with matric number 1913243, and inshallah I will present about the hemophilia. Okay, next slide. Hello, can you hear me? Huh? Yes.
The slide not moving ke?
Hello. Dengar ke?
Dengar.
Okay. So this is my outline for my presentation today. So firstly, I will go to introduction, and next inherited pattern, and then pathophysiology, classification, clinical presentation, investigation, and lastly management. So firstly, we go to the introduction. So next slide. Say okay. For the introduction, what is the hemophilia? Hemophilia is actually a group of blood disorder in which there is defect in the clotting mechanism, or we call it as coagulant cascade. In order to understand this topic, actually we need to recall our lecture during year 1 about the hemostasis. Okay, what is the hemostasis? Hemostasis is defined as process by by which our body spontaneously stop the bleeding and maintain the fluid and maintain the fluid within the vascular system. So this hemostasis is actually involved two components. The first one is procoagulant, and also and the second one is anticoagulant. So these two components actually need to be balanced lah in order to achieve hemostasis in our body.
Your slide ni memang tak jalan ke?
Slide dekat introduction sekarang tu.
Masih kat introduction lah. Okay, alright.
Okay. So under normal condition, I mean without any trauma or any injury, procoagulant pathway will not activate actually to avoid from blood clotting lah. So in normal condition, the anticoagulant will activate actually to maintain the vascular system. So in this topic, hemophilia is actually the problem is involve the procoagulant or coagulant cascade, which are defect in clotting factor. So when there is injury, so the patient with hemophilia cannot stop the bleeding, so it will be dangerous lah. And hemophilia is a X-linked recessive disorder, so it means that hemophilia is involved sex chromosome or chromosome number 23. We know that apa male patient have male have apa chromosome XY, right, and the female have chromosome XX. So if the male inherit a gene, a hemophilia gene from the parent, so he will automatically will suffer from hemophilia lah. Meanwhile, for the female, when she inherit one of the gene from his parent, she will have a carrier of hemophilia, and if she inherit two gene, so she will suffer from hemophilia lah. And the most common hemophilia is two, which is hemophilia A and hemophilia B. Hemophilia A is a defect of factor number 8, which is consists of 85% of the cases. And meanwhile, for the hemophilia B, it is a defect of the factor clotting number 9, which is consists of 15% of the cases. So next we go to the next slide. We go to the inheritance pattern. So this slide, actually the mother is a carrier, and the father does not have hemophilia. So the chances of the male children to have hemophilia is 50%. Meanwhile, for the female children, the chances of female children to have carrier is 50%. And the overall of from this situation, overall the possibility to get hemophilia children is 25%, and the carrier is 25% too, and the healthy or the normal children is 50%. Okay, next slide. Okay, next slide. In this slide is father has hemophilia. Meanwhile, the mother does not have hemophilia or not a carrier. So the chance it is 0%. The chances of the male children to have bleeding disorder or hemophilia. And meanwhile, there is 100% the possibility female children to have carrier. So overall, from this situation, from this condition, the probability to have hemophilia children is 0, and the carrier is 50%, and the healthy children is 50%. So next slide. And okay, for this slide, the father has hemophilia and the mother is a carrier. So
Sorry. I rasa yang tadi yang first tu kan, yang second one tu kan, kita boleh kata 50% chance of carrier and 50% chance of normal. Because kalau buka balik the previous slide tu. Okay, so kalau yang previous slide yang father ada hemophilia. Okay, so this one bukan assuming dia akan ada 4 children tau. So you punya probability tu kena based on dia punya gender. So gender kalau male 0% will be takkan hemophilia dan takkan carrier lah kan. Males cannot be carrier kan. So dia ada disease ataupun tak ada lah kan. So you tak boleh kata dia 50% ada carrier ataupun 50% tak ada hemophilia lah. So you only can say is if it's male is 0%, if it's female is 100% dia akan jadi carrier. Okay, so you tak boleh kata 50-50. Macam ni nampak dalam gambar ni memanglah macam 50-50 kan. But this is the permutation je kan. Okay, okay next.
Okay, next. Okay, for this slide, the father has hemophilia and the mother is a carrier. So the chances for male children to have blood disorder or hemophilia is 50%. Meanwhile, the female children, the chances to have a carrier is 50%, and the chances to have bleeding disorder also 50%. Okay, next slide. Next, we go to the pathophysiology. Okay, this picture is actually show the coagulation cascade. And coagulation cascade consists of two pathway, which is intrinsic pathway and extrinsic pathway. And this hemophilia is actually involve the intrinsic pathway, whereby there is defect in factor number 9 and number 8 for hemophilia B, as you can see from the picture. So actually, this coagulation cascade is very important to us to understand and to remember, because in order to we have a specific test to diagnose hemophilia patient by looking at this intrinsic pathway. I will explain after this. Okay, next. Uh, as I mentioned, hemophilia is a genetic defect on the X chromosome that affect the factor number 8 for hemophilia A and factor number 9 for hemophilia B. So since it involves X-linked, so it most commonly affect the male patient. But the hemophilia patient, the platelet is not affected, so the platelet count will be normal. And in the hemophilia, there is a deficiency of functional factor number 3 and number 9. So as I showed the slide just now, this factor
The three.
8. Oh, sorry, 8. This factor number 8 and 9 actually involved in the intrinsic creatine pathway. So the PTT test will increase. PTT test or protothrombin time is a test to assess the integrity of the intrinsic and common pathway. So it will increase in this patient. And for the uh, and the PT will be normal because hemophilia not involved extrinsic pathway, and PT is a test to assess the integrity of the extrinsic and common pathway. And when there is insufficiency of the clotting factor, there will be a control bleeding. So when when the bleeding occur across the entire body, it will be manifest as hematorosis, bleeding in joint, intramuscular hematoma, dental bleed, intracranial hemorrhage, and GI and genital urinary bleeding. And in severe patient, the repeated joint bleed is common, and we call it as chronic hemophilia arthropathies. Okay, next we go to the classification. Okay, for the classification based on the PIC protocol, it can divide it into 3, which are mild, moderate, and severe. And for the mild, the factor level count is about 5 and 25, between 5 and 25%. Meanwhile, for the moderate hemophilia, the factor level is 1 to 5%, and the clinical presentation for this mild and moderate is the bleeding may only occur with trauma, surgery, or dental procedure. And for the severe, the factor level is less than 1%, and the clinical presentation is the bleeding is spontaneously occur, and it is a high risk to get intracranial hemorrhage. Okay, next. And next, we go to the clinical presentation. In history, usually the patient with hemophilia will come to us with bruising and bleeding. Firstly, we need to ask the site of the bruise. It can be at the joint, and if it occur at the joint, and it is a hallmark for the hemophilia lah. It also can involve muscle, gum, nose, brain, and gastrointestinal. And next, we need to know the onset of the bruising. Usually for the hemophilia patient, it started to occur. The bleeding started to occur when the child start to crawl and walking. Usually in 9 to 12 months old, because when the child start to crawl or walking, it may cause injury to his body, so it will cause bruising lah. And next, we need to know about the severity. We can ask whether the large area of the bruising, and we need also ask about the aggravating factor, whether the bruising occurs spontaneously, and if spontaneously, it is a severe manifestation lah for hemophilia. And also we can ask about whether the bruising preceded by trauma. And for the we also can ask about the associated symptom like lethargy, pain in joint, muscle, pain in joint and muscle, blood in urine, abdominal pain, blood cherry stool, and neurological symptom. We also can ask about the past medical history. We can ask about the previous surgical procedure, circumcision, multiple bowel extraction, because this procedure can cause the bleeding. And also we can ask about the previous trauma and also liver disease, to exclude the liver disease. And also we can ask about the family history. We can ask about the bleeding disorder that occur in family. So next slide. So this is a picture for clinical presentation of hemophilia. The first one is easy bruising, and the second one is gum bleeding, as you can see on the left side at the bottom, and the middle one is hematorosis, and the right side, the upper right side is hematoma, and the lower one is epistasis. Okay, next slide. Next, we go to the investigation. Firstly, we need to do foot blood count. Usually, hemophilia patient hemophilia patient will have a normal foot blood count, but some of the patient might have low hemoglobin due to loss of blood. And next, we can do the screening by doing protothrombin time or PT. And usually hemophilia patient PT test is normal because it not involve the extrinsic pathway. Meanwhile, and next we do the activated partial thromboplastin time, or APTT, and it will prolong in hemophilia. And the platelet count will normal in this patient. And we also need to screen the von Willebrand factor, because it will overlap with the hemophilia. Okay. So if the hepatitis is prolonged, we need to do a mixing study. So if the mixing study is actually to a test to differentiate whether the hepatitis is prolonged due to factor clotting, or due to inhibitor. So if the hepatitis is corrected, it suggests factor deficiency, and if hepatitis is not corrected, it suggests presence of inhibitor. Next, we also can do specific factor assay. The first one is we need to do factor 8 level. It is low in hemophilia A, and we need to do also factor 9 level, and it is low in the hemophilia B patient. Okay, next slide. We also need to check the virus status of the patient with hemophilia, because hemophilia patient is high risk to acquire viral infection, especially hepatitis B. So we need to screen. We need to do the hepatitis B surface antigen and anti-hepatitis B surface antibody. And also we need to do hepatitis C antibody, HIV serology, and also we need to do liver function test to exclude liver disease. Okay, and also we need to tackle or we need to diagnose the carrier in the family for the genetic counseling, especially for mother of a newly diagnosed son with hemophilia, female sibling of boy with hemophilia, daughter of a man with hemophilia. Okay, next slide. For the management, the principle of the management for hemophilia is ideally the treatment should be prophylactic to prevent the arthropathy and ensure the best of quality of life. And the prophylaxis, for the prophylaxis, we can give factor 8 concentrate for hemophilia B, 25 to 35 unit per kilogram, and given every other day or 3 times a week. And for the we also can give factor 9 concentrate for the patient with hemophilia B. Okay, about 50 to 60 unit per kilogram, and given every 2 to 3 days. And it is actually costly and require central venous access. And for the factor replacement therapy, we can give uh, factor 8 concentrate for hemophilia A every 8 every 8 to 12 hours. And for the factor for the hemophilia B, we can give factor 8 factor 9 concentrate every 12 to 24 hours. And for the replacement therapy, we do not use frozen plasma and precipitate to avoid risk of viral transmission. Okay, actually, it depends on the for the dose of the factor therapy. Factor replacement therapy is actually depends on the severity of the bleeding, and if hematorosis, we need to give 20 unit per kilogram for the factor 8 and 40 unit per kilogram for factor number 9. And if soft tissue if it if the bleeding involves soft tissue or muscle bleed, we can give 30 to 50 unit per kilogram for the factor number 8 and 60 to 80 unit per kilogram for the factor number 9. And if intracranial hemorrhage or surgery, we need to do 50 we need to give 50 unit per kilogram for the factor number 8 and 100 unit per kilogram for the factor number 9. And the duration for the treatment is depend on the severity of the bleeding also. For the hematology is actually between 2 to 3 days. For the soft tissue and muscle bleed, it is 4 to 5 days, and for the intracranial rate, it is 7 to 10 days. Next, we also need to give supportive treatment. First, we can give the analgesia to relieve the pain, to relieve the joint pain, and we need to avoid intramuscular injection. And we do not, we does not, we actually cannot use aspirin or NSAID because this will affect the palate function. And next is dental care. Oral hygiene is very important, and we need to make sure the patient with hemophilia have a good oral hygiene. because data carries regular sources of bleeding. And data clearance with factor replacement will be required in severe case, actually, to avoid severe bleeding. And we need also give immunization, especially hepatitis B. Hepatitis B need to, according to the PEAK protocol, hepatitis B need to be given all the patient with hemophilia. And the preferred site is subcutaneous, and it is give under factor to cover if the hematoma are the problem. Okay, I think that's all for me. Thank you.
Okay, Bismillahirrahmanirrahim. So I will continue the next presentation about the leukemia. So next slide. So basically this is my outline. So we will discussing about the introduction of the leukemia, classification, pathophysiology, discussing also regarding the acute lymphoblastic leukemia and acute myeloid leukemia, the complication and the prognosis, and also differential diagnosis. So next slide. So before going further, so we must know the definition of the leukemia itself. So based on the Davidson Principle and Practice Medicine 20th edition, leukemia is defined as a malignant disorder of the hematopoietic stem cell compartment characterized by increase in number of white cell in the bone marrow and peripheral blood. Leukemia actually there is what happened in leukemia. Actually, in leukemia there is uncontrolled and abnormal hyperproliferative mature white blood cell, in which it's leading to bone marrow failure and also organ infiltration. In simple words, leukemia is basically a white cell malignancy, which originating from the bone marrow and going to the peripheral blood. So next slide. Sorry. Okay, I found this on the web to control and hyperproleating. Okay, so regarding the epidemiology of leukemia. So leukemia is the sixth most common cancer in Malaysia population, where actually acute leukemia is the most common form of malignancy in children. Not only form of malignancy, but in general, the most common form of malignancy in children, whereby this cancer occurring among the age of 0 to 14 years old. So the incident rate in West Malaysia, it is counted 3 to 4 per 100,000 children below the age of 13 years old. And about 70% of the leukemia cases are all associated with, acute lymphoblastic leukemia cases, and about 18% is non-lymphoblastic leukemia. So chronic myeloid leukemia are relatively rare in childhood. Why? This is basically because the chronic type of leukemia is a disease of the adult. So next slide. So most cases of leukemia actually have unknown or idiopathic in origin. However, there are some factors that might increase the incidence to develop leukemia itself. So there are the factors that might lead to leukemia have genetic factors and also environmental factors. So the factors are, in genetic factors, there is chromosomal disorders such as in Down syndrome, trisomy 21. So, and other than that, Wiskott-Aldrich syndrome, the Fanconi anemia, ataxia telangiectasia, and identical twin with affected parents. Other than that, if there is any chromosomal abnormalities, which is a Philadelphia chromosome, whereby it is a translocation in the 922. So for the environmental factors, so environmental factors is exposure to chemicals such as benzenes, and also involvement of drugs such as chlorambucil and procarbazine, and of course the exposure to radiation such as nuclear generators. So basically this is the factors that might lead to development of the leukemia. So next slide. So classification. So leukemia can be classified into two classification, which is acute leukemia and also chronic leukemia. So let's see the first classification, which is the acute leukemia one. So basically, acute leukemia is an undifferentiated, involve the immature, also known immature cells, or also known as blood cells, and it is a rapidly fatal cause. So in acute leukemia, it is further subdivided into two types, which is the acute lymphoblastic leukemia, ALL, and the second one is acute myeloid leukemia, AML. So ALL, as I already mentioned, it is the most common one, which is it account for 75% of cases, and the peak incidence is occurring at the age of 2 to 3 years old. So for AML, it is account for 20% cases where it is a stable incidence which happen in less than 13 years age of 13 years age, and the case is increased in adolescents. And so for chronic leukemia, it is actually a mature leukocytes. However, even though it's look mature, it is still not functioning well or have abnormal function. And it is a relatively indolent cause. So in chronic leukemia, it's subdivided into two types also, which is the first one is the chronic lymphoblastic leukemia, CLL, and the second one is the chronic myeloid leukemia, CML. So for CLL, the incidence account for 15%, where the peak incidence happen in 30 to 80 years old. As I already mentioned, chronic type of leukemia is a disease of the adult, and it is rare in children. So for CML, it is the least one, account for 3%, and the peak incidence is happen 40 to 60 years old, and it is rare also in children. So next slide. Regarding the pathophysiology of the behind the leukemia. So now let's understand what is the pathophysiology behind the leukemia. So leukemia actually can happen if there is a contributing factor that lead to the development of the leukemia, such as involvement of the genetic factors and also environmental factors, as I already mentioned before. So those things, the environmental factors and also the genetic factors will lead to either point mutation in the DNA or chromosomal abnormality, in which this can lead to duplication, loss of sequence, or recombination error. So a combination of these genetic defects will cause in reduced tumor suppressor genes. However, it will increase in oncogene expression. So what will happen? So the precursor of the white blood cells, as an example, we take a lymphoid, which will supposedly differentiate to lymphoblasts and further differentiate to make the either B cell or T cell. It will stop at the lymphoblast state, where it is lose their ability to further differentiate. It cannot differentiate to form the B cell and T cell. However, it is retain the ability to replicate. So it will produce a blood cell which is immature, however loss of function, but keep in proliferating. So what actually will this proliferative immature blood cell do? So it can three things he will do, which is the first one is replace, and the third one is the metastasis. So replace. It will replace most of the bone marrow cells and crowding out the normal hematopoiesis. So it will lead to pancytopenia, and the patient might come with fatigue, and also the patient also will easily get infection, and also there will be mucosal bleed or epistaxis due to thrombocytopenia. And the second one, it will enter the peripheral blood, in which it will result in increased blood cell in the peripheral blood and lead to leukostasis. And the last one, it will metastasize. So it will metastasize throughout the body and infiltrate organs such as organ, liver, and spleen, whereby infiltration of this infiltration of this organ will lead to hepatosplenomegaly. So next slide. So our focus today is discussing about the acute leukemia and not discussing about the chronic one. So acute leukemia, as I already mentioned before, it is divided into acute lymphoblastic leukemia, ALL, and acute myeloid leukemia, AML. So acute lymphoblastic leukemia, it is, as I already mentioned before, it is a rise from early cell in the lymphoid series and have a genetic association with Down syndrome, hyperliploidy, which is the trisomy 21, and it is also associated with translocation 922, which is known as Philadelphia chromosome. So regarding the classification of the ALL, it is have a immunophenotype classification and French American British FAB classification. So based on the immunophenotype classification, it have a precursor B cell acute lymphoblastic leukemia, which is the most common one, and it is also common in Down syndrome child, since it is a lymphocyte, so it will positive in CD10, it will positive in CD10, CD19, and also CD20, 20 plus. However, it is associated if it is associated with Philadelphia chromosome, it will carry a bad prognosis. Other than that, it is or have also the T cell acute lymphoblastic leukemia and also B cell acute lymphoblastic leukemia. So regarding the acute myeloid leukemia, AML. So acute myeloid leukemia, actually it is arises from the pluripotent cell or the myeloid progenitor cell. So it is have also association with the Down syndrome. Other than that, it is have association with aplastic anemia, Fanconi anemia, and the previous history of chemotherapy. So regarding the classification of the AML, it is follow the French American British classification system. So if you can see, it is classified from M0 until M7. So we, I think, no need to remember everything. However, it is need to remember the common, the most important one. So one of the most important one is the M2 type, which is the most common known as the myeloblastic, with maturation and have a translocation in at 21, where it is carry good prognosis. Other than that, the one of the important to know is also the M3, which is also known as the acute promyelocytic leukemia, and it is associated with deep disseminated intravascular coagulation. And the interesting part of the M3 type of AML is we can actually treat it with a vitamin. Vitamin what? Vitamin A, and it is a carry favorable prognosis. So the last one, the important type of the AML is the M5. So M5 will presented with gum infiltration. So the patient might will presented with gingival hypoplasia. So that's a little bit of what we need to know about the classification of ALL and AML. So next slide. So regarding the history, so what we should ask the patient. So the first one is the bone marrow abnormality. So in bone marrow abnormality, we can ask if the patient have a pallor, lethargy, signs of anemia basically. And other than that, there is a signs of thrombocytopenia such as a bruising, petechial, gum bleeding, or epistaxis. Other than that, we need to also look at the signs of neutropenia. So if there is an infection, prolonged fever, or mouth ulcer. Other than that, we should also see or ask about the bone or joint pain, where the patient might have a limping or pain at the sternum area. So other than that, we should also ask the patient regarding the constitutional symptoms, because this is a case of cancer. So the patient might presented with malaise and lethargy, loss of appetite, and also loss of weight. So regarding the past medical history, we need to ask regarding the previous hospitalization and the recurrent infection. And for the family history, of course, we must ask the family history of malignancy, especially regarding the hematological malignancy that is have hematological in origin. Other than that, it is important for us to ask regarding the consanguinity marriage and the siblings with who have a same condition. Next slide. Other than that, it is also important for us to ask the developmental history, whether the patient have a failure to thrive, it seems less active and decreased social interaction. And for the birth history, we should ask if birth weight, if the baby is SGS, small gestational age, or premature, or even IUGR. And we should also ask the mother regarding the postnatal complication, if have complication because of the pregnancy. So other than that, regarding the immunization history, is it the immunization history is up to age or not? So the last one is social history. So regarding the environmental condition, is there any exposure to any radiation or chemical exposure such as benzene? So next one, next slide. So this is basically the clinical presentation in leukemic patient. So as I already mentioned before, leukemia will infiltrate organ. So the presentation of the patient is depending on the organ that involved, or organ that infiltrate. So for generally, the patient might look malaise or anorexia. However, when there is a bone marrow infiltration, the patient again will present with the anemic symptoms, thrombocytopenia, neutropenia, bone or joint pain. However, if it is involved the reticular endothelial system, the patient will be presented with hepatosplenomegaly, lymphadenopathy, or even superior mediastinal obstruction. And if it have other organ infiltration, such as the central nervous system, the patient will have a headache, vomiting, convulsion, and nerve pulses. And if it is involved the testis, it will have a testicular enlargement. And if it's involved the kidney, the patient might have acute renal failure. So next slide. So basically, this is on physical examination, what we can find through the physical examination. So on the general condition, we can see a typical presentation of person with cancer, such as there is alopecia, and in leukemia patient, they are also might look pale due to anemia. Other than that, there are also lymph node enlargement, but it is painless because it's cancer. Painful lymph node might indicate it is an infection. So if there is swollen lymph node with painless, it is most probably due to cancer. Other than that, there is also a nosebleed or mucosal bleeding due to thrombocytopenia. So on the skin, what we can see is there is a red spot noted on the skin, which is this is known as leukemia cutis, which one of the findings in patient with leukemia. Other than that, on the abdomen, what we can see is the abdomen was distended, probably due to hepatosplenomegaly. So next slide. So basically, this is the general symptoms or signs that we can see in the leukemic patient. So next slide. So let's discuss about the lab investigation that is important in diagnosing to help us diagnose the leukemia. So the first one regarding the food blood count. So the food blood count, it will have anemia, either normocytic or macrocytic type of anemia. Why can it be microcytic? Because it can be microcytic due to a folate deficiency, because folate is used up in the production of synthesis of new white blood cell. That's why it can be macrocytic. So other than that, the white blood cell count can be low, normal, or increase, depends on the infection. So there are also thrombocytopenia. So on the peripheral film, so what we can see, it is a variable number of blood cells seen. So in acute lymphoblastic leukemia, in the first picture, so what can we describe from this picture? So basically, in this the presentation of blood film with acute lymphoblastic leukemia have a few, which is it is no granules, it is increased nucleus to cytoplasmic ratio with scanty cytoplasm, and it have a less prominent nucleoli. However, in acute myeloid leukemia, in AML, the presentation of the peripheral blood film, it have a large but immature blood cells, immature cells, and it is more cytoplasm compared to the lymphoblast. The nucleoli is a more prominent, and it is a granule. And the important one that we need to note about the AML is the presence of our rods, whereby our rods is actually azurophilic needle-shaped granule. Other than that, we can do also a bone marrow aspiration, where in bone marrow aspiration, we can see the hypercellularity, whereby more than 20% of blood cells scenes and the normal hematopoietic cells are suppressed because of the blood cells. Other than that, we can also do the lumbar puncture. So the lumbar puncture, the blood cell will be seen in case if there is involvement of the cerebrospinal fluid involvement. So next slide. Other than that, we can also do the chest X-ray, where in chest X-ray, we can see any mediastinal mass, whereby in mediastinal mass, it is due to enlargement of the thymus, as you can see in the picture I've provided there. So it is the enlargement of the if there is a mediastinal masses, it is associated with the T cell type of acute lymphoblastic leukemia. The last one, what we can do is the cytogenic and molecular studies. So it is involving the chromosomal analysis, immunochemistry, immunophenotyping, IgG T cell receptor gene, and rearrangement study. So what we must look for any chromosomal abnormalities. So next slide. So let's go regarding the management of acute lymphoblastic leukemia first. So in managing the acute lymphoblastic leukemia, so the important one that we need to know is the induction of remission and also consolidation. So what actually the induction of remission? It is basically mean that we induce the state of the remission of this cancer cell. So by how? Basically, it by killing the rapidly most cells in order for the patient to enter the remission state. So in order to do that, there are a few steps, which is the combination therapy for 4 weeks, and the remission rate is 95%, which is it is a high rate of possibility to be successful. And the multi-agents that involve is such as the vincristine, daunorubicin, L-asparaginase, steroid such as prednisolone and dexamethasone. So if we already achieve the remission state, so we must prolong the remission state. So this is where the consolidation phase takes places, where the consolidation phase is actually function to prolong the remission phase so that the cancer is not relapse, and it will also increase the survival rate. So it is have a block of intensive chemotherapy to consolidate the remission and to bring down the tumor burden to a very low level, and it is also improve the cure rate but have a high risk for complication. So the multi-agents that involve RC, cyclophosphamide, etoposide, and the CNS prophylaxis, which is across the blood barrier. And other than that, it is the intensification, whereby 2 to 3 blocks of intensive multi-agent chemotherapy to clear the submicroscopic or if there is any minimal residual disease. And then we need to maintain the state of the consolidation and remission by maintenance chemotherapy, which is to 2 to 3 years of chemotherapy as an outpatient patient, and the modest intensity continue over the 2 years for girls and 3 years for boys. So next slide. So this is a remission criteria for the patient with leukemia. So the remission criteria, the first one is there is a less than 5% of blood cell in the bone marrow, or totally absence of blood cell in the peripheral blood film. And the second one is the restoration of the normal peripheral blood counts and the absence of extramedullary involvement. And the child, the last one is child is physically well or normal. However, this leukemia is a cancer that can relapse. So there is a management of the relapse. So management of relapse involving the intensive chemotherapy and cranial irradiation and CNS for the CNS relapse. And it does also have a high dose chemo plus minus the total body irradiation. And if it is the cancer, and usually if the cancer usually attack the CNS, the patient might presented with polyphagia. If the involved in the testis, there will be painless unilateral swelling, and if it involve the bone marrow, it will presented with pancytopenia. So next slide. So we already discussing the management of the acute lymphoblastic leukemia. So let's see the management of acute myeloid leukemia AML. So basically the step is almost similar, however, which is it involving the induction of remission and also consolidation. So for induction of remission in acute myeloid leukemia, it involve the agents such as daunorubicin, cystosin arabinoside, and also thiaguanin. So in study shows that more than 80% will achieve remission. And however, if the remission step is not achieved, so bone marrow transplant is necessary. So for the consolidation phase, basically in consolidation phase, it is same as induction regimen that use. There are also intrathecal chemotherapy plus minus the irradiation if the CNS leukemia at the diagnosis, or it is involving the CNS relapse. And for further consideration, it is involving a total 4 to 5 courses of multi-agent chemotherapy such as etoposide, cystosin arabinoside, and also M-amascrin. So bone marrow transplant is usually only considered after relapse of acute myeloid leukemia in children. So basically, there's a little bit of management in acute leukemia. So next slide. So in the acute criteria for remission in acute myeloid leukemia, almost the same of in the acute lymphoblastic type of leukemia, whereby there is a less than 5% of blood in the bone marrow, or totally absence of blood cell in the peripheral blood film. or if there is a restoration of normal peripheral blood counts, and also absence of extramedullary involvement, and the child is physically well or normal. So for the management of relapse in AML, it's involving the intensive chemotherapy, intrathecal chemotherapy, and cranial irradiation in the CNS relapse. So bone marrow transplantation offer best chance of cure. So common signs of the relapse in AMLs involving the bone marrow. However, it is rare in CNS. So next slide. So this is basically the complication of the acute type of leukemia, whereby it can the complication involving the bleeding and anemia. It might have a neutropenia, significant bacterial and fungal infection. It is also can involve the cell-mediated immunosuppression. As you can read, and the last one is there is a tumor lysis syndrome, which can cause hyperuricemia, hypophosphatemia, and hyperkalemia or hypocalcemia. So regarding the prognosis of the acute lymphoblastic leukemia, it carries a good prognosis in translocation of 1221. However, it carries a bad prognosis in translocation of Philadelphia chromosome, which is the translocation 922. And it is also carry a good prognosis in female hyperdiploidy, and it carry a good prognosis in 2 to 10 years for acute lymphoblastic leukemia, and less than 4 weeks to remission. However, it carry a poor prognosis when the patient have high initial white cell count, and as I already mentioned before, it carries a poor prognosis in Philadelphia chromosome, which is the translocation 922, and it carries a poor prognosis in male with hypodiploidy, and carry a poor prognosis in case which happen less than 2 years old or happen in more than 10 years old, and it is also poor prognosis if there is any CNS involvement. So for prognosis of acute myeloid leukemia, so overall cure rate for acute myeloid leukemia is 60 to 70%. And however, the cure rate depends on the type, which is highest for M3 type of acute myeloid leukemia. So the prognosis decrease with the increasing age in acute myeloid leukemia. So next slide. So this is basically differential diagnosis in acute leukemia. So the differential diagnosis can involve the infection, non-infectious, or malignancy. So you can read by yourself. So next slide. So basically, this is a practice question that you can try to answer if you have a free time, and if you want to read back the slide that I have provided. So next slide. So basically, that's all from me. I think I invite doctor to give any comments. Thank you.
Okay, thank you all presenters. I think there's a lot of information within the past 1.5 hours kan, 4 topics on, mainly hematological problems lah. Okay, so you have one is your punya platelet punya abnormality, and then number 2 you have you punya hemoglobin abnormality, number 3 you have you punya coagulation factor punya abnormality, and then you punya leukemia, which is mainly your white cell count, usually bone marrow abnormality lah as a whole. So any question regarding any of the topics, okay, that you are not sure? I mean, I know it's a lot to take in lah, but I think you have to go and read back after this lah, a lot of the informations presented today. Any questions?
Assalamualaikum, Dr. Presenter. I'm Shahida. I would like to ask regarding thalassemia.
Okay.
For the signs of thalassemia, why do we need to check for the hypothyroid signs?
Macam mana?
For
Thalassemia.
thalassemia, like why do we need to check for the hypothyroid signs?
Usually for complications lah, screening for complications of thalassemia. Okay, you can have iron deposition in your thyroid. So you can have iron deposition, it can cause reduced function of your punya thyroid glands, causing hypothyroid lah.
Understood. Thank you, Doctor.
Alright. Anything else?
I have a question. I want to ask regarding the hemophilia. My question is usually for the hemophilia, what is the complaint that they came to the hospital? Or it is just
okay, there's a lot of it depends on severity. Okay, depends on severity, but most common complaints is actually bleeding lah, kan? Okay, bleeding. So ada some come with like very bad bleeding, hematrosis, intracranial bleed, baru dapat diagnosis of hemophilia. Okay, some come with delayed prolonged bleeding time after surgical procedure lah. So macam dia lepas buat circumcision and then noted bleeding tak stop, ataupun go for some dental punya procedure and then bleeding tak stop after 1 hour. So those are the moderate types lah, selalunya kan. Mild moderate types ni usually they present with any surgical procedure kan, dia ada prolonged bleeding. But some yang severe tu usually they present with easy bruising lah selalunya, easy bruising. So this is when they come early, they will present as easy bruising lah. So ada some patients yang actually dia memang ada easy bruising but tapi never seek any treatment. Never seek any treatment, kata oh this is maybe just a spontaneous bruise, tapi tiba-tiba datang dengan ICB, datang dengan very bad hematrosis ke, baru diagnose hemophilia. When you go back to dia punya history tu, actually memang ada history of spontaneous bruising tapi never seek any treatment lah, ataupun bila pergi seek treatment you never check the coagulation profile lah. Okay, so it's a variety of presentation lah. There's no one presentation that is more common than the other lah. Okay, some just incidental finding je. Okay, just memang datang untuk some buat screening and then noted prolonged epidity, just incidental finding saja. Ada yang setengah tu macam during neonatal period pun ada yang present juga, datang neonatal period present dengan prolonged bleeding of you punya umbilical stump. Okay, this is your congenital hemophilia, yang maksudnya the mother ada carrier and then dapat baby boy lah. So baby boy ni dia akan jadi hemophilia lah kan. So baby boy akan jadi hemophilia. So datang dengan umbilical stump bleeding, prolonged umbilical stump bleeding, ataupun after bagi IM vaccination post delivery tu dia develop hematoma, ataupun datang dengan subapneutic hemorrhage lepas buat some vacuum delivery ke, dapat some SAH ke kan, subapneutic hemorrhage bleeding of the scalp lah. So datang dengan some present in the neonatal period itself lah. So bila biasanya this mother yang ada carrier lah. Okay, okay. Any question lagi? Does that answer your question?
yes.
There's a variety of presentation lah, but usually most is associated with bleeding. Okay. So you just have to keep an eye on the family history too. Sometimes we miss out on the family history of thalassemia. Hemophilia, family history of bleeding disorder. Okay. Because we have one patient actually datang dengan fitting episode lah. And I think 6 months macam tu datang dengan fitting episode, and then buat CT noted intracranial bleed, but actually the mother punya relative ada memang a lot of history of thalassemia carrier lah, but the history was not disclosed earlier, so miss out the diagnosis of hemophilia. So dah hantar ke neurosurgical, baru noted dia punya APTT prolong, baru diagnose dia punya hemophilia. So luckily the surgeon didn't go in for the ICB lah, otherwise it would be tragic lah for the baby. Hemophilia, you go for intracranial surgery without giving any factor replacement, so dia akan mati from bleeding intra-op nanti lah. Okay.
Understood.
Anything else? So all these are quite common diagnosis that you will find in the pediatric population lah. ITP, thalassemia lagi lah common kan. Hemophilia pun is quite common, 1 in 5,000. Hemophilia A kan. Hemophilia A. Okay. So you have to know how to make the diagnosis, what are the complications. Okay. So hemophilia ni complication mainly usually is a joint problem lah kan. Chronic joint problem. They have chronic bleeds into their punya joint. So they have hematrosis, so destruction of the joints. So you punya prophylaxis tu is to prevent this joint bleeding lah actually, to preserve dia punya joint punya mobility. Okay, any more questions?
I have another question. I have question regarding leukemia. For the leukemia, since this occur in children, so that means that the management can help to cure it, or is it just he have to live with it?
Leukemia?
Yes.
Leukemia in children mostly is very good prognosis. So provided diagnosis early, and then start chemotherapy, radiotherapy, whatever chemotherapy treatment that is available, you start early, and then provided that they follow with the maintenance therapy, actually cure rate for leukemia is very good. The prognosis of leukemia is very good for young children. Okay, so they can be completely cured lah. Okay, I mean most of the common leukemias, the prognosis cure rate is a more than 90% survival rate. Okay, more than 90% survival rate. Ada some with the new treatment can go up to 95-98% survival rate. Okay, so leukemia usually in children is very good prognosis provided they go for treatment properly lah. Okay, kalau default treatment lah apa benda semua tu, of course lah they not going to be cured lah. Okay, always leukemia in children is a good prognosis usually, unless they present late lah, and then ada certain types of leukemia, that mean the prognosis is not so good. But as a general rule, leukemia in children, the prognosis is actually quite good with the treatment nowadays.
Okay, thank you.
All right. Okay, lagi ada soalan lagi? ITP tak ada soalan. Okay, kalau tak ada soalan, I end our today's session. Okay, if you have any question regarding the topic, you can text me lah. The WhatsApp eh.
Okay, doctor.
Thank
Thank
you,
you,
doctor.
doctor.
Thank you, doctor.
Thank you, Doctor.
Thank you, doctor.
Okay.